Thank you, and thank you for the organizers for inviting me. So we'll talk about my experience as intensivist, and in a a specific topic, which is family-centric care. As you probably know, when I was a student like you, the dominant model of care was paternalism. It was assumed that the patient was not competent to understand the disease, so the doctor had to decide for them. And on the basis of what did we decide? On the basis of what the doctor knows about the disease, and on the basis of what he, the doctor, would do for himself according to his own experiences, emotions, and fear. The patient was then only a group of symptoms, but not a human being capable of deciding alone. It creates a relationship of superiority with some kind of infantilization of the patient, and due to that, the patient has psychological consequences that might be harmful for him. For example, we'll talk about compliance a little bit in 2 or 3 slides. Well, it was before 1945, but as you know, if you went on hospital, it's still the case. It's still the case in many places. In oncologic consultation, the patient is not invited when we are talking about him. We are talking about him without him. I think it's a problem. When you do stuff in the morning, you are talking about patient, but the patient is not here. This is not a good practice. In the US, when there is staff with, let's say, 10 people, the people goes in the room of the patient. It's not the case in Belgium. And if you ask to American physicians what they prefer in terms of decision-making process, 14% of physicians say that they use paternalism and that they don't ask the patient what he wants as to be treated. And the risk factor for that are old physicians and physicians that are internists. I think it's quite the same in Belgium. However, gradually the medical community has come to accept the importance of informing the patient, probably more out of fear of legal consequences than out of real conviction. Maybe you don't know, but in France and in Belgium, there are more legal consequences of a surgery than in the US. The surgeons are going more in the law court than the US. You think that in the US is the most dangerous country for practicing medicine, but it's not true. There is no publicity about that. That's the difference. In the US, it's said in the journals and so, not here, but the real danger is here. And I think that paternalism is a great cause of conflict between the surgeon and the patient. And so continuing to do paternalism has also legal consequences for doing medicine. So now we change, and Balint in '69 was the first to talk about patient-centered care. It was a new word in '69, so it's not, 100 years ago. It was real close of us. And what is patient-centered care? It was an informed approach. People had to inform the patient. They wanted to let the patient have an autonomy, and now autonomy is considered as legal in Belgium and also as ethical. You have to let the patient choose, but you've seen that 14% of physicians don't respect law and ethics. Many of the people that thinks that they do autonomy just give information to the patient, but don't imply the patient in the treatment. They don't really want to know what he wants. They just inform the patient, but they make the choice when they are informing the patient. They don't give choice to the patient. They say, you're gonna be operated next week. The patient has no choice. And the risk of the surgery is that and that, but they don't talk about choice. And so the patient is more in that kind a link between professional than a real active people. And this is not the best way to do that, but when you will go with doctors in your practice, you will see that many people are thinking that autonomy is that. And so the patient is a passive actor in that kind. And is it good to be passive, to just receive the information and that the doctor just has to be sure that the patient has understood what he asked? Well, in Belgium, in a study in 2012 showed that 50% of chronic patients stop their treatment. So you think you treat them, you have chosen the right treatment, but 50% of them don't take it, and so don't recover. And actually, it's not a Belgian problem, because it's the same in the rest of Europe. And it costs money, because when the patient don't take the treatments, he make complication, and complication are costing money. So people estimate that it costs around 8% of annual healthcare expenditure in Belgium. So that's a real problem. Compliance is a real problem. And psychologists say that this passive position of the patient led to that. The patient inactivity gave him the feeling of being outside the therapeutic process. If he's not active, he is outside, and if he outside, he won't take the treatment, because that's not his treatment, it's the treatment of the doctor. And so he don't understand why he has to take it, because it's not implied, you know. Everybody knows that when you are a student and where they ask you to be in the corner of the room and be passive, then you are not you're not implied in the treatments. So that is the same thing. So there are, of course, risk factor about compliance, and you see that poor doctor-patient relationship is one of the risk factor. The lack of belief in benefit of treatment is a risk factor. So you have to change, and doctors have to imply the patient, and it's the solution for that. And I'm sure that everybody that is treating a patient wants that the patient get better. And so when you know that 50% of your patients don't take the treatment, you have to ask, you have to make something. And I'm surprised that many of my colleagues don't care about that, don't care at all. One thing that will probably change the vision of my colleagues is the new law with the electronic prescription that is starting in the 15th September, because from that point, every doctor will see if the patient went to the pharmacy and took the treatment or not. So you won't have any more a black box. From October, you will know if the patient takes the treatment or not. And so I hope that all this passive treatment will change to active treatment, because when the doctor will see, you don't take my treatment, I hope that an interaction will start, and that there will be a discussion, and so a kind of active response from the patient. So I hope this law will change. That's why my union has supported that new law. And so maybe you can think that if you are a doctor, you will be persuasive, and that you will understand the feelings of the patient, and then you don't need to have the patient active. You just have to convince him, and it's cool, and that the patient don't need to be implied in the relationship, because he don't know, you know. He's not able to understand the physiopathology, for example, and so why to imply him? But actually, if you think that illness is just due to a patient characteristic, but WHO has defined illness as an interaction between three things: between characteristic of the patient, but also between desire of the patient, and also an interaction with the environment of the patient. And you know the first one. You never know the last one. Many doctors don't know where the patient lives. And you think you know the desire of the patient, but we'll see a little bit later that most of doctors has a false sense of knowledge of the patient wishes. When you make a comparison, you will see that we never know exactly what are the wishes of the patient, even in a chronic relation. And so you may say, okay, autonomy of the patient is that the patient has to decide alone, but when the patient is deciding alone, he makes bad choices. We are thinking, we are talking about patients that decide to do MRI for any reason. And if you let the patient do, he will do MRI every time he has a little pain somewhere. And we are all convinced that we are the regulator of that, that we have to stop him. So why to make him let choice? Because all these choices are bad, because he don't have our knowledge. But this is a not good way of thinking autonomy. Actually, autonomy is a shared decision model. You can be autonomous and having to share the decision of your own autonomy. You know, an example of that is wedding. In wedding, you have autonomy, but if you want that your wedding gets long, you have to make a shared decision model with your wife or your husband. It's autonomy in a shared decision model. And I think that the medical relationship has to be like that. So when you make empowerment of the patient, engagement of the patient, there are now many studies that are showing that the share of knowledge creates less error. The patient sometimes say, oh, you know, if I well understood what you said, I think that you made a wrong decision. Why? Oh, because, okay, sorry, I forgot the treatment. There is a quite better compliance. There is a better confidence. The studies show that there is more self-confidence of the physician. There is more self-confidence of the patient in the way that he can, in the things that he can do with his disease. So he dares to do many more things. And there is a confidence in the team that you are forming with the patient. There is also less readmission at the hospital, only with just changing the decision-making progress. So it's surprising, but many studies show that. And we see that what is getting better is lifelong. So it's really important to go in that way. I've told you that when we ask the doctors what were the wishes of the patient, the doctors went wrong. But actually, the only way to know what the patient is to end all consultation with only one question: what is important for you? After that question, you can discuss about treatment. But if you didn't start it with that question, you will choose a wrong treatment, and you will propose to the patient a wrong treatment. Who is asking to the patient during his consultation what is important for you? I'm asking you, who? And when we ask the patient what is important for him, what matters to him in the therapeutic relationship with the doctor, we see here that the response are not the same as the doctors think they are. Many doctors think that, for example, competence of the doctor is very important, but patient, only 8% of the patient are citing competence. What is important for patient is respect for dignity and individuality. That's the most important. It's crazy, you know. Nobody thinks that before that study, but it's the reality. Why? Because if the patient decided to go to you, he thinks you are competent. The other thing is that if he chooses a doctor in Belgium, he thinks that due to the medical study in Belgium, all the doctors has the same competence. That's why people think. We know here that is not true, but we are the exception in Belgium. Many of people, except 8%, are thinking that we have all the same competence. So it's really important to understand when you have a patient in front of you. And so, okay, we'll say he has autonomy, he may choose what he wants, but does he really want to choose? And when we ask to a citizen in the street if he wants to be participating in medical decision, if he has to be in critical care, 90% of citizens say, yes, I want to be implicated. But when he is in the critical care, only 47 of the patients say, okay, I still want to be implicated. The majority just say, I want the doctor to do his job, and I don't want to decide for my husband, for my son, or so on. They don't want to decide anymore. And in Canada, it's not the same. The percentage in Canada is 71%. So we have a problem in Europe. We are pushing the family and the patient not to decide, because we are pushing them in a way where decision seem to be too hard, and we'll see a bit later why. And another question we may ask is, why do we incitate paternalism? Why doctors decide that even if they know that compliance is bad? Because it's hard to empower the patient. It's hard to let him have autonomy. Why it's hard? There are many reasons, and you know these reasons. For example, you have to have an adapted language to the patient you have in front of you, and sometimes you don't understand nothing about biology, nothing about medicine, and so you don't speak your own language. So it's not easy, and that's just an example. I have so plenty of reason why. And another reason is sometimes the truth is too hard to be told. I have some professor that told me that if he had a severe disease that was terminal within the year, the professor decided never to tell the patient that he will die in the year. That's why I have heard in my studies. So it was very shocking for me. And the reality is that you don't have to give just right reality. You have to expose reality with tact and measure. So you have to choose the right time, and maybe to give digestible quantity and to see patient many times. You don't have to kill psychologically the patient, but it's possible. It's always possible. In my practice in critical care, I give information of imminent dying every week. And I don't have suicide every week. So it's possible, but you have to have technique. You have to be formed to that. You need formation. And another thing that it's necessary for empowerment, for autonomy, is that what you say, the patient have to trust you. And so the prerequisite for that is trust between the patient and trust is not easy. You know, studies show that trust needs many things, and that there are some threats about trust, because you know the science change, the therapeutic is uncertainty. Sometimes you don't see every time the same doctors. So how to trust someone that change every time you go to the hospital? And so all these reasons are threats for trust, and that it's not easy in medicine to have trust and to keep trust in the time. So it's really, you have to be active, and you have to accept some failures sometimes. And you need time. And the problem in medicine now is that there is a lack of time. The doctor don't take the time to have trust with the patient, and that's our main problem, and it's due to the system, so we have to change the system. That's also why I'm the union, to change that system and to give more time to the doctors. And you have time, but you also need architecture. And one example, if you want to do patient-centered care, is the difference of architecture. You know, at the left side, you have nurse-centered care. The principle of that unit is that the nurse don't have to take time to go from room to room. So it goes quicker, but there is no intimacy. You cannot talk with a patient in such a big room. It's not possible. But when I started critical care 10 years ago, more than 80% of the critical care units in Belgium were like that. There are only few units that were single room like that. That's my unit right now here, but it's rare. Now there are still many units of critical care that are like that, and not even in the COVID-19 period, in all the periods. So that's a problem. And you know, there was a problem of privacy, but there was also a problem of risk of infection. When you are here, of course, the infection goes in every bed. And so you have to change architecture. And so when we started to do a patient-centered care and to think about autonomy, we've soon decided, we soon think that it was necessary to start debating with the patient. And so we need to be concerned about the patient needs. And when you are deciding that, suddenly you think about what leaves the patient in the room. And then you go into an ICU, and what is the first thing that you see when you go in the ICU? I don't know if someone of you went in the ICU one time, but when you go there, you have a lot of noise, you know, alarms, beeps, many things are making noise, and it's noisy. Actually, the noise in the ICU is around from 60 to 70 decibel. And the WHO say that for recovery in a hospital, you have to have a sound less than 35 decibel. So you are not in good condition to recover and to sleep. It's almost impossible to sleep without medication in the ICU. Almost impossible. And so we say, why that? It's because of all the beeps of the alarms. And when an alarm sounds, who do you think that should be able to hear the alarms? Is it the patient that has to hear the alarm, or the nurse that has to hear the alarm? That's the big question. Who is in the best position? When you are on call, on duty at home, would you like to have an alarm ringing in all the room, in all the house, of just an alarm in your phone near you? I'm sure you say an alarm near you, but we don't do that in the intensive care. So we decide to do something and to think solution for making a silent ICU. So that's what we did in my unit. We made a silent room, and how we did that? We did that with kind of smartphones in the pocket of the nurse, and it's ringing and it's vibrating when there is an alarm. And there are also big screen where the alarms are in the walls, and so they are less loud. The other one that is doing that is the NICU, so neonatology in UZ Leuven, but we are the only one in Belgium. The other one, they have 80 decibel. So I think that's not, we are probably two that are really patient-centered care, but the other are probably not. And you can go higher. I say that I want that the patient has the autonomy. I want to talk with the patient, but 50% of my patients right now with COVID are intubated, are not conscious. So I can't talk with them. You know, you can talk with intubated patient only on TV. In other words, the tube is in the larynx, so you cannot talk with them. And so, how to do that? if you then have the patient, you will ask the family, and so we come in family-centric care. And so we have to imply the relatives in the medical decision. Every time, no, only if the patient agrees. So if the patient, before being intubated, before being sedated, say, I don't want you ask to my family, we don't ask to the family, then we have a legal authorization for deciding for the patient and not to ask the family. But it's the only exception about that. Or if the patient didn't say that, we are forced by law to ask the family what the patient wants. It's the law of the rights of the patient. And so we have to imply the family. And it's legal for all incompetent patients. So I mean children, I mean people in delirium. It's the law. You don't have choice. But many of doctors don't do that, don't discuss with the family. And you can maybe ask you, it's not legal, but in geriatrics, I think that it's useful to integrate the family in the decision. Why? Because the family in geriatrics are not just visitors. You know, family is suffering for the consequences of the disease if they love their old ones. Family can give information about the patient that the patient don't give. If you go to a geriatry department, you will see that family knows sometimes better than the patient what treatment the patient takes. You will need the family for home care planning to organize home caregivers and so on. You will need them in your site, so they have to understand the problem. And the family is the best coach for the patient. You know, when the son of the little son of a patient asks him to take the treatment, he takes the treatment better than when the doctors ask them. I see that every time. And so I think it's useful. And so, as I've said, if you want to engage the patient, and when the patient is in some condition, you have to go to family-centric care. And so family-centric care is a new word created by intensivists in 2003, a French intensivist. And we have no literature to show that this is beneficial for the patient. So we'll discuss a little bit about that. And from that time, from 2003, in ICU, there are international awards for best architecture in ICU. And the units that have received the recent awards for best architecture have integrated the family into the ICU. This is an example. You see that there is a big place for the family in the room of the patient. But you see also that in movies about medicine, because in the US it's going to be the norm, not yet in Europe, and that's so the winner of 2008 ICU design, and you see at the top of the room that there was a little room close that is the family zone, where the family can go, sleep, stay, and so on. And this is critical care room, so the patient has dialysis, is intubated, and so on. So it's the most severe patient. But it's quite logical. When your loved one is between life and death, where do you want to be? Do you want to be at home, or do you want to be near him? I'm sure you want to be near him. It's logical. And the patient is the same. If he's conscious, and he knows that maybe he will die in the day, what he wants to have around him, nurse that he don't know, or his loved one? I'm sure that he wants his loved one. He has to be reassured. So when you are putting yourself in place of the patient, you understand the needs of the patient, and then you understand why to do that. But you have to change your mindset, and it's the first thing you have to do. And so the question is, if you implies the family in the decision about the patient, and sometimes in ICU you make decision about stopping a life. You decide we were too far, we have to stop, or he don't have any chances to survive, so we'll stop the treatment. And so, is it good to let a family choose about stopping a treatment? Doesn't have psychological consequences like post-traumatic stress disorder, for example? Well, and then you don't have to do that because the rule in medicine is primum non nocere. And well, it's true that when you implies relatives of ICU patient, you see more depression, 35% more depression, 70% more anxiety. So there is even post-ICU family syndrome that is described. And so it's really dangerous, and it lasts all the life, so it's really dangerous. So there are people that say, let's stop doing that. But the reality is more complex than that, and we'll see why it's more complex. And when you do that bad, when you create anxiety because you don't make family participating in a correct way, of course you have consequences. And another one is that when the patient is awake after that, and that you compare the decision of the family and the decision of the patient, you see that 20% of relatives made a bad decision. That was not the decision of the patient. And in 50% of the time, when we ask the family after decision what they had understood of the pathology and for which reason they decide to do that, in 50% of the case, the reason were not good. It was an incorrect understanding. So that's the real problem. And you have to find solution to avoid that. And we people made study to understand why they have anxiety, why they make incorrect understanding. And the biggest link is the duration of the meeting. Actually, in these studies, the mean time of discussion about a life decision was 16 minutes. And in the 16 minutes, the doctor talked 11 minutes and let the family only talk 5 minutes. So we say to the family, you have 5 minutes to decide life or death, give your arguments. And in 5 minutes, you also have to make me understand what you have understood of what I've said. In a life decision, you don't even buy a car in 60 minutes, you know? You take more time for buying a car than for life-death decision, so it's crazy. So that was the real problem, it was time. You need more time in the ICU to discuss about life-death decision. And it was real, you know, the study shows that the interview condition was the real cause to PTSD, anxiety, and bad decision. This is not due to the system, to the autonomy. This is due to the way we do the system, the autonomy. And so you cannot improvise that. You have to follow guidelines to make a good communication with the relative. The best thing would have that the communication would be taught in the studies, but it's not the case, you know. It's a rotten system here in Belgium. And so it's in the continued formation of my team. They are forced to learn adaptive communication, and they have learned that. And so they know that we need time and we need technique to be sure that the family has understood what we say. For example, we make them repeat in their own words, but that's an example. Huh? The guidelines is more than 10 sheets, so it's a big thing. I need more than an hour to explain that. And of course, you have to discuss in the patient, not in the room of the patient. You have to discuss in the family, not in a corridor, you know, like in many units. You have to discuss with them about life, death decision in a good place. That's example of place in hospital that are that use the best practice. This is, for example, in Utrecht. Utrecht is one of the best architectural ICU in the world. We receive many awards about that. And when you do that in a correct way, the results change. You augment satisfaction. You reduce psychological sequels compared to not to decide. And so you change everything. So that's the proof that the problem is not the autonomy. And then now we have a new way of doing care that's called Humanizing Care. There is a group in LinkedIn and conferences and an association, an international association about that. And there are different goals, and we'll discuss a little bit about the other goals to humanize the patient. And when you humanize care, you see that family are implied every time. So that's why I'm talking about family-centric care. When you do this whole stream of good practice, it will lead you to rethink your practice toward a more human practice. And critical care is medicine in the middle of machines, of robots, and in the middle of unconscious patients. So it's easy to end up working like robots, because if you want, you can avoid to see any human being during all the day. It's possible in critical care medicine. So it's a real danger. But as I've said, a stay in critical care for a family and for a patient is a tragedy. It's the worst thing you can have. You've seen in COVID-19, when a relative of you has been admitted to critical care, you know the emotion that you had. You know that it's not just like going to a consultation. So you have to be more to humanize that. You don't have to be like machine. But in the new medicine, which is called lean medicine, where management and governments are constantly asking to the doctor to be more productive, to treat patients, you know, like car on assembly lines, to have standardized medicine. One might get the impression that there is no room for humanization because of that. We are treating Toyota, not any more patient. And we know that we call about industrialization of healthcare. You can see that in papers now. So that's a real problem. And the end of that is that before that, medicine was an high-touch system. High-touch means with many human relationship. You know, you have the patient in front of you, but no, you don't have the patient in front of you. You have a screen in front of you and the patient after the screen. When you go on consultation, sometimes you don't only see the air of the patient. You know, you don't see anything else. It's really crazy, you know. And it's now low touch, high tech, and it's called patient-centric, but it's computer-centric actually. And that's a problem. And that's a problem. And now they are studying that show that in front of the computer, the doctors lose the real meaning of their work. They lose the taste of the profession, and they end up with hating medicine, and they hate their computers. And then burnout is not far away. You know, burnout is not due to the time you spend in the hospital. Burnout is due to the time you spent in front of a computer in the hospital. We have studied about that. If you have a neurosurgeon and that you spend more than 10 hours a day in the operating room, you don't have burnout. If you spend 7 hours in front of the computer, you have a high risk of burnout. So it's crazy, but it's human relationship and loss of sense of the work. And when you're on the front of the computer, what's the sense of making 6 years of studies to be in the place of that stupid computers? And a wonderful article, but it's 26 page, so it's a big article, but I think you have to read that. Just go to Google and you Google that and you think that it's in the New Yorker, it's in the Annals of Medicine, it's a free, so you can go read it. You have to read that. You will laugh, but then cry, because it is just all the stupidity of the system described in that really good article. And it's called, it talks about the best computer system in the world of medicine. It's called EPIC. You know, UCL Saint-Luc has bought this. But it shows that EPIC might be the best angel in the world or the best devil in the world. It depends on how you organize the system. And you will see a new profession, a profession of scribes. Now, in the US, in some hospital with EPIC, they pay for a medical student that is right next to the doctor just to put information in the computer, and then the doctor is just talking with the patient, because when he has to do the two, it takes too much time, and so the organization don't want to pay him for that. So the organization asks the doctor to stop to talk with the patient and to use the computer. And the doctor say, no, I don't want, and so they buy no scripts. And after the medical student, now they are buying Indian doctors in India that are from remotely coding in the paper, and the doctor is just with his own mobile phone, and then the Indian doctor is in the computer. So it's crazy. It's a crazy world, and I hope in Saint-Luc it won't be the same, but it's a danger. And why that? Because for cost saving, many hospitals has fallen in the commodity trap. The commodity trap is to go from high touch to low touch or no touch, and high tech. You earn money with that. But if you want to do good medicine, you don't have to earn money. You have, with the same amount of money, doing something else thanks to high tech. And something else might be spend more time with the patient, because high tech can help you to have more time with him. You have artificial intelligence that helps to make diagnostics. And the computer may help you to, in one click, just prescribe 10 or 12 treatments, and then you earn time. And that time you have to spend with the patient. If you don't do that, if the hospital asks you, thanks to that, to see more patients in an hour, you have lost everything. You have to go in the high-tech, high-touch. And you have to make understand to the hospital that high-tech, high-touch is building loyalty. The patient will be loyal with you. You create trust then. And if you create trust, the patient comes back. If you don't create trust, the patient won't come back. It's the case. High-tech, high-touch is now the politics in the high-level hotelry, in the hotels, in big hotels. They understand the interests of high-tech, high-touch. In banks, they start to do that also. You may now have an appointment with someone in the banks. It takes time for you. It takes time because the computer makes routine when he is with you. And so with the same prices for the bank, he has time for you. So that's high-tech, high-touch. I have other examples of high-tech, high-touch and avionics and so on. There are many. And in the hospital, it's beginning. Mayo Clinic is the best example of high-tech, high-touch. But in Europe, I don't have example to show you. That's not a good news for us. And also entertainment parks are making high-tech, high-touch. If you went to Disneyland, Florida, you see that you will have only one key, and the key is opening your room, is entering in the park, paying you everywhere. You have the bill all the times in your mobile phone, so you don't spend time at the cashier to pay. You don't pay at all, actually, from the start, from your stay to the end of the stay. And so people that are in the shops now are giving you advices, are discussing with you, and now making you pay. So it's high-tech, high-touch. They didn't ask to the cashier to leave from Disneyland and to earn more money because they didn't have to pay her. They asked her to be there, but to give advices. And what happens? They sell more. It's like that. So in the hospital, they have to understand that that kind of technique makes them having more money. So it's not, but you have to think that the expense is not an expense, but an investment. And so in some CEO of hospital, it's not possible to think like that. And so I'm sure that high-tech must help doctors, and IT must help doctors, and must help doctors to two things: to reduce the time without patient, and must help doctors to have better results in treatment. And I'm sure that the informatics will do that, but in some years. Right now, sometimes informatics take you time and give you less good results, because the software are not doctors oriented. So you have to fight against that when you are in the hospital. That's why I'm in the medical council of my hospital, and we are changing of software this year. So I'm fighting to have a software that is doctor oriented and patient oriented, but it's not easy. And I tell you, you will have less burnout, and so the hospital also has interest to have less burnout. So even the regulator, even the government has understand that. 5 years ago, the objective of the government was the triple aim. So the healthcare in Belgium has to follow triple aim. It's a concept of an American concept that is widely used in the world. But now the new minister changed that, and the triple aim is not anymore that the aim of healthcare in Belgium. It's now four aims. Why? Because now the patient comes second and not come first. You know, in Mayo Clinic, the rule is the patient come first. But many people, and this is a book, a really good book, say if you want that the doctor thinks about the patient, he has first to be in wellness. You know, if the patient is in burnout, he cannot give help to the patient. So the first thing you have to do is that the healthcare practitioner has to come first, and then when they are happy, when they have joy at work, they can give joy to the patient. And so the priority is to let people come first. And so now we have a credible aim. It's brand new. I'll just say one word about visiting hour. If you want patient and family oriented, you have to let people go in your unit. And in Belgium, it's not the case. You know, 98% of ICU open maximum 2 hours a day. And we decide to open the door, and there are trials that show that open the door gives good results. In my unit, we are opening from noon to 20 hours, like the rest of my hospital, and the objective is to open 24 hours. But it's an objective because you need a framework for that. You need architecture, and you need to go higher resistance. So it's a good job. Is it good for the patient? Yes, because having a loved one near you reduce stress, reduce ischemic events, reduce many things. And so this is good for the patient. And you don't have effect on medication error or nosocomial infection. So all the risks that people say in order to resist to change are not true in the studies. And you know, when we let people stay in the room all the day, the mean time of presence is 2 hours, because they don't want to stay at the hospital, you know. It's like us, we don't want to stay at the hospital. So it's not a problem, but you have to have a good architecture. It's the unit in Utrecht, for example. And you can go even more far. We did that. Like the team of Azule. When we have a CPR, we let the family enter and see the CPR. But when we did that first, it was a failure. There was stress in the family. It was a total failure. So if you do that, it's like all the other things. You have to make rules, to make protocols, and to know what you have to do when and how, and so you have to prepare that. You cannot do that without preparing that. So that's why we know. And we called Eli Azule. We asked him his tricks, and now we have a protocol for doing that. So all family-centered care must be done with protocols and with rules. And if you don't do that, you have more anxiety, more stress disorder. So you have to ask people that did that before to give advices. And all these guys are giving advices, and I have many visits in my unit of other head of department of ICU that wants to do that. They come at us, and we give them all the procedure, and then they are doing that. So we are all very happy to do that. And you can go more far. We also did that. We have people that comes to and doing music, and in Johns Hopkins, in the ICU, they let dogs entering in the ICU. For the Belgian hygiene, it's impossible in Belgium. I asked to the regulation, it's not possible at all. Even in pediatrics, it's forbidden. And so, my experience, if you want to make family care, is that you have first to open minds of nurses and doctors, and then you can open doors, because there is really resistance in change. And then the things will change in a very good way. You know, the family acknowledge the work of the nurses, and we are receiving many gifts in usual time, because no, the problem is that we have to stop to have visitors due to COVID-19. So in Mars, it was not possible anymore to have visitors, but we try to have to receive now more visitors, and I'm sure that in a few days we will have a great reopening for visitors in the ICU. At this time, we didn't were able to make 24 hours visiting hours at this time, because we are still have around 15% of COVID-19 patients in my unit. But I hope that in January we will be able to open the doors like before. And so this is my conclusion. If you want to do family-centered care, you have to follow 4 concepts, and you need architecture, you need organization, and you need a training. You cannot start this with just goodwill, you know. But you have to have also a global willingness. If people don't want to do that in your unit, it will be impossible to deploy that. So I thank you.